And some other breast concerns that women have come to me for. I also wanted to talk about the task force findings that came out in 2009. And one thing they suggested was mammograms don't need to be started until women are 50 years old. And that made a lot of controversy, a lot of women writing letters to the editor and everything about, oh my God. So I wanted to talk about that. I also wanted to talk about the Women's Health Initiative. That came out in 2006. That was a study done of 160,000 women. And up to that point, it was like all women who went through menopause went on hormones. And the Women's Health Initiative, this very big study, said, oh, no, wait, we shouldn't all be doing that. It causes more harm than good. So women were like, oh, and women stopped taking Premarin and other estrogens in droves. So I wanted to talk about that a little bit. I wanted to talk a little bit about breast cancer, breast halo that we have, and some other things that are out there, including maybe some of you have heard recently the controversy about taking calcium supplementation. And it causes heart attack. Oh my God, what are we supposed to do? So I wanted to talk about some of those things. First of all, has anyone ever seen such a disgusting bug? This was in my garage. Have you ever seen, I don't even like to look at it. Have you ever seen something like that?
I've seen that in my house too.
Have you? It was so horrible. We have an exchange student, I had to go wake him up and say, oh please Tim, there's a creature in the garage, you have to take care of it. And he was like, oh my God. That has nothing to do with breasts. I just thought I'd put that in there. Anyways, so some breast concerns that I get lots of questions about: breast pain, breast lumps, nipple discharge. And you have to excuse me because my notes are hidden and I can't see them. I studied, but I don't think I'm going to remember everything. Breast concerns. Breast pain is a common complaint that I get. One cause of breast pain, puberty. Real common as girls' breasts are developing. They usually start developing around 7 to 13. They can develop up into the early 20s. Puberty causes breast pain. Pregnancy causes breast pain. That can be one of the first symptoms that tells you you're pregnant. About 2 weeks after conception, start getting breast tenderness. And breast tenderness can happen in the first, second, or third trimester. Common cause of breast pain. Menstrual cycle, real common cause of breast pain just before the period. So some suggestions what to do if you have real breast pain associated with the period: decrease salt for the week before your period, decrease caffeine, get exercise, and some women taking birth control pills can decrease the pain of cyclic pain. Caffeine, another well-known cause of breast pain, especially in women who have fibrocystic breast cancer. Breastfeeding, of course, can cause pain. It's well known. If the baby isn't latching on right or it's really causing pain, then it's suggested talk to a lactation consultant. Another cause of breast pain, hormone replacement. And they did find in the Women's Health Initiative that women who had more breast pain who had started on hormones. So they started on hormones. The women who had more breast pain were at higher risk for getting breast cancer. So the speculation is the hormones they take caused more breast cell turnover and more breast cancer. But that's to be researched more. Another cause of breast pain, I know this isn't a breast, it's a back, but that's herpes zoster. You can get herpes zoster on a breast, it can be very painful, but herpes zoster you would get on one side of the body, and it would be associated with a rash that looks like that. More causes of breast pain, of course, injury, costochondritis, which is an inflammation of the, beside the sternum of the cartilage, thank you. Inflammation of the cartilage. Some medications can cause breast pain, like hormone replacement can cause breast pain. Digoxin, methyl-dopa, a couple others. Infection, but if you get an infection, it's generally associated with breastfeeding. If you get an infection and you're not breastfeeding, just need to make sure there's not a cancer there. Breast cancer is one of the last causes of breast pain because it's not a common one. That's why it's listed last. So breast pain rarely indicates breast cancer. So another concern that women have is breast lumps. Very common, and women who have fibrocystic breast tissue need to not do so much of the caffeine. That makes the lumps worse. And monthly, the breast lumps will be worse just before your period. But if you do have breast lumps, they can be aspirated. Usually breast lumps are full of fluid. You just put a needle in, draw the fluid out, and they're gone. Nipple discharge rarely means breast cancer. But if a woman has nipple discharge that is occurring spontaneously, that means she's not touching her breast, it's just discharge is coming out of the nipple, and especially if that discharge is bloody on one side of the body, not two, those are more concerning things, and that does need to be evaluated. So, the U.S. Preventive Services Task Force in 2009 came out with some new recommendations. Now, the task force is composed of physicians and epidemiologists who look at the whole country and all the screening tests that happen, and what screening tests really make a difference. What really has more good than bad. The benefits outweigh the harms of doing it. So they looked at mammogram, for one, and what they found is that for women, well, first of all, let me say, the grading. They graded each recommendation by grade A, B, C, D, or I. If they give a grade A to a screening test, that means this screening test is really good. You should do it. The benefits outweigh the harms. A grade B means it's good to do it. The benefits outweigh the harms. It's not tremendous benefit, but there is some benefit to doing it. A grade C means the benefits don't clearly outweigh the harms, but consider the individual. And in some individuals, you might want to do this screening test, some not. If something gets a grade D, that means, no, the harms outweigh the benefits, you should not do that test. And a grade I, like you see up here, a grade I means it's indeterminate. They really can't decide if it's a beneficial thing or a more harmful thing. So looking at mammograms, the task force looked at women from 40 to 49 and said that's a grade C recommendation. That overall, the average woman, the benefits do not clearly outweigh the harms in doing a mammogram. This is a regular film mammogram from ages 40 to 49. So women will say, hey, but lots of women below 50 get breast cancer. That's right. This is for a screening mammogram where a woman has no problems, no lumps, no large family history of breast cancer. They just have a screening mammogram, and the task force found the benefits, considering the cost and everything else, does not make sense, really, for women from 40 to 49 to get mammograms. For women from 50 to 74, it does make sense to get a mammogram every 2 years. They put it as a grade B. You know, it's not even a grade A, but a grade B. Yeah, it makes sense to do it. And then women over 75, they gave it a grade I, because women over 75, you got to consider, 75 or older, they may have some other medical problems, maybe heart issues. And if a woman is, say, 78 years old and she's got some real heart issues, you do a mammogram and you find a breast cancer, maybe that breast cancer would kill her in 5 years maybe, but maybe her heart would kill her in 2 years anyways. So as you get older, it doesn't make as much sense. Now you got to consider, you have, and you've certainly seen, women who are 80 years old or more, they're still riding their bicycle, going to Heavenly to ski every day. I've seen that. And they're very active, very with it. They're involved in all the groups in town. Absolutely sure, give them a mammogram, because they're probably going to live well into their 90s or 100. So yeah, you give them a mammogram. But you kind of consider the woman there. See that? Yeah. So this chart shows comparing a screening film mammogram to digital mammogram, MRI, clinical breast exam, and breast self-exam. And the recommendation here is a grade I. That means compared to a film mammogram, it doesn't really makes sense to do a digital mammogram compared to a film mammogram. So there's insufficient evidence to show that it's clearly beneficial. The same for MRI, same for clinical breast exam. Now, clinical breast exam means you go into a healthcare provider, they check your breasts to look for lumps or problem, whereas of course breast self-exam is doing it on yourself. And look at that, a grade D for breast self-exam. They recommend against teaching breast self-exam. Whoa, that's a change, huh? So the rationale for a grade I on the digital mammogram, magnetic resonance imaging, MRI, and clinical breast exam, evidence is lacking for benefit for the digital mammogram and MRI as a substitute for film mammogram. So in other words, do the film mammogram and it's really just as good as far as they can tell. The evidence of clinical breast exams, it says evidence of clinical breast exams additional benefit beyond mammograms is inadequate. That means if you have a mammogram, you do it. If you have a mammogram, that doesn't really make sense to do clinical breast exam, just do the mammogram. Now, if you don't have a mammogram, then, yeah, you want to do a clinical breast exam, and it will, in fact, find a few cancers. But they're saying you don't really need to do the clinical breast exam if you have the mammogram available. And then under the breast self-exam, evidence suggests breast self-exam does not reduce breast cancer mortality. So if they look at all the women across the country, and if they teach the women to do breast self-exam, it's not going to make them live one day longer than women who do not get taught that. And there are some harms from it. See, the harms of breast self-exam and clinical breast exam is that you'll end up doing more biopsies and mammograms and visits and imaging of different kinds. They're going to cost money, they're going to make the woman anxious. So those are the harms of doing those. So as far as digital mammogram, potential harms, there is probably some overdiagnosis. Consider a digital mammogram compared to a film mammogram is just like the pictures you used to take in the olden days. You know, you took a picture, you sent the film into Rayleigh's, you got it back, and you got these little pictures. Compared to your cameras nowadays, digital, you can blow up one area, you can email it to a friend, you can, you know, you can look at any area of it really well and magnify any area. Same with digital mammogram. you can magnify areas and really find things more. So they're afraid with digital mammogram, they're going to be more overdiagnosis, finding things. Oh, there's a little thing. Oh, we got to follow up on that. Oh, turns out to be nothing. MRI is famous for getting a lot more false positives and potentially overdiagnosing than mammogram. MRI, you know, is a giant magnet that that is very good at finding some cancers, but really only in high-risk people. I'll get back to that. Considerations for practice. Younger women and women with really dense breast tissue, detection is somewhat better with a digital mammogram. In younger women, they have dense breast tissue. As women get older, breasts are replaced with fat, and they're not so dense anymore, and mammograms work better then. But in younger women, mammograms do not work quite as well, so doing a digital mammogram works better. And then with MRI, they do contrast-enhanced MRIs, which detect more cases of cancer in very high-risk populations than with mammogram. So MRIs are not used in the general population, but you got to consider, some women are at very high risk. Say they've got a mother and a sister with breast cancer, they've got a very high risk of cancer, right? And you will find more cancers in them. In them, an MRI makes sense to do because it will find more cancers. So in those high-risk groups, you do MRI, you find more cancers. If you take a low-risk group where there's not very many breast cancers at all, consider doing MRI for them. You're going to find more problems. You're going to overdiagnose, and you're going to end up overtreating them. So MRI is really best done in women who are really high risk, more apt to have breast cancers. Otherwise, you're going to get a lot of false positives, and that's not good. And I already mentioned about clinical breast exam, detecting some cancer cases if you don't have a mammogram available. So, how bad can it be to teach women breast self-exam? Well, the current recommendation on breast self-exam is that you don't teach women to do breast self-exam, but you teach them to have breast awareness. You teach them that look at your breasts every month, feel your breasts, be aware changes that your breasts go through, be aware anything new that's happening to them. Is there a rash? Is there a rash on the nipple? Is there a red area? Is there something different? So we teach breast awareness now, not breast self-exam. All right. Women's Health Initiative. That's what changed GYN practice across the country. Came out in 2006, and I'm sorry my notes are not in front of me, so I'm going by memory. It was over 160,000 women that were studied, and there were two parts of this Women's Health Initiative. There was a clinical trial, and there was a observational study. In the overall goal of the Women's Health Initiative was to look at what are the risk factors that lead to diagnosis, lead to osteoporosis, breast cancer, and diabetes. That's the main thing they wanted to look at. So with the two studies they had, one was an observational study where they didn't have the women do anything. They just gave them questionnaires and asked them about what you eat and what supplements you take and what medicines do you take. And it was like 8 years. So it's a long time to look at what women were doing over that period of time. 15 years total. The clinical study looked at hormone replacement therapy, dietary modification, and calcium and vitamin D. Hormone replacement therapy had two groups of women. One group of women took, the women who still had a uterus took Premarin and Provera, Premarin 0.625 and Provera 2.5 milligrams. And the women without a uterus took plain estrogen, actually the 3. And then there was a group that took the placebo. So the women who did not have a uterus took plain Premarin, 0.625 milligrams, and since they didn't have a uterus, they didn't have to take the Provera. And then a group just took sugar pills. That was a hormone therapy trial. In the dietary modification trial, I love that picture. That dietary modification trial, they had the women eat a low-fat diet with lots of fruits and vegetables and whole grains, fruits and vegetables, low fat. The other women, they just told them, eat whatever you want. The calcium vitamin D trial, that's Mono Lake. We were just there recently canoeing, but the water was much higher, so this is an older picture. But Mono Lake, the tufas, are made of calcium carbonate. Anyways, that's an aside. The Women's Health Initiative, the calcium vitamin D trial, they had the women take 1,000 milligrams of calcium supplements. In vitamin D, they took 400 international units of vitamin D every day. So the results on the hormone therapy trial, the group that was taking the Premarin and Provera, because they had a uterus, they ended up stopping that trial early because they noticed increased strokes and heart attacks. The group and breast cancer. The group that was taking the estrogen alone, they stopped that a couple of years later, but sooner than they were planning to, because they noticed more strokes in that group. The women continued in the trials and being watched for the rest of the time, but they just didn't take the hormones for the rest of that time. Let me see if I need my notes for this one because it's hormone trials. The study found that overall health risks exceeded the benefits in the use of Premarin plus progestin when they were followed for 5.2 years among healthy postmenopausal women. This trial did not find the prevention of any chronic diseases. It didn't prevent diabetes, any of those. This regimen should not be initiated for primary prevention of coronary heart disease. We used to believe that if you give estrogen to women, it's going to decrease heart attacks and improve everything, decrease Alzheimer's and everything else. And it's like almost a fountain of youth. So we used to kind of believe that. And this study showed no, in fact, the harms outweigh the benefits. In the estrogen alone arm, women received the Premarin, or they received the placebo, the sugar pill. The use of Premarin alone increased the risk of stroke, decreases the risk of hip fracture, and does not affect coronary heart disease incidence over a range of 6.8 years, because they did keep that study going a little bit longer than the other one. A possible reduction in breast cancer was seen in the women taking estrogen alone. So that needs to be investigated further. The other diseases were all the same. There was no change in diseases between the estrogen alone and the sugar pills. There was an excess risk of 12 additional strokes per 10,000 person years and an absolute risk reduction of 6 fewer hip fractures per 10,000 person years between the women taking estrogen alone or none. So there was more strokes but less hip fracture if you took estrogen. One problem though with this study, as you notice, it was a study of women from 50 to 79 years old. And I don't know any women much older than 55 who are not menopausal. So they were taking women that were much older, had been menopausal for quite a few years, perhaps off of hormones, were putting them on hormones for this study. So it's thought that that's part of the problem. don't wait till women are 10 or more years after menopause and put them on hormones. And it was a pretty good dose of hormones. It was Premarin 0.625. It was a pretty good dose of it. So you don't want to do that. Also, these women being older, they had some chronic medical problems. So the current recommendation for hormones is when women first go into menopause, usually around age 50, you can give them hormone replacement, and you can give it up to maybe 5 years, as long as you explain to them you do have some risk, you have some increased risk of stroke, perhaps breast cancer. Women who have a very strong family history of breast cancer, you want to let them really understand that they may be at higher risk. Although in the Women's Health Initiative, there was slightly less breast cancer in the women taking estrogen alone. So it's a confusing issue. Let's see, I think. Okay, and then the dietary one. This was really surprising, and I don't really know what to make of it. Oh, there we go. Now I can see it. Yeah. So the dietary intervention that reduced fat intake and increased intake of vegetables, fruits, and grains did not significantly reduce the risk of coronary heart disease, stroke, or colorectal cancer in menopausal women. And it achieved only modest effect on cardiovascular disease risk factors, suggesting that maybe they needed to really diet more strictly and it needed to go on for a longer period of time. There we go. The calcium vitamin D results was that daily supplementation of calcium with vitamin D for 7 years had no effect on colorectal cancer. We used to be hearing that taking calcium also decreased colon cancer. Well, they didn't see that in this. But it takes a long time to develop colon cancer, and they're thinking, well, maybe it just needed more time on calcium to prevent it. They don't know. But among these women, calcium with vitamin D supplementation resulted in a small but significant improvement in hip bone density, but it didn't decrease their hip fractures. But it did increase the risk of kidney stones. So then it comes to, sorry. So what is it? Is calcium a monster or a sweetheart? And people have been hearing that calcium is bad for you. Well, there was a study in Germany that came out earlier this year. It was like May of this year. And it was published in the journal Heart. It studied 24,000 people in Germany. And it followed them for over a decade. And the results suggest that calcium supplements cause heart attack. Well, the findings also appear to go against previous studies that have shown a higher calcium intake is linked to a lower risk of heart disease and stroke, high blood pressure, obesity, type 2 diabetes. So this study studied people, men and women, who were 35 to 64 years old. They started in the study between 94 and 98, and the study was centered in Heidelberg, Germany. They filled out questionnaires that assessed their diet for the previous year. Of course, if you're asked, what did you eat for the last year? Yeah, I never ate ice cream. I never ate candy. I only ate healthy foods. Yes, I rarely, eat a steak. Yeah, right. So that's not a very good way to do a dietary recall, to ask people what they did for the past year. So that's not a really good way to set up the study. They were also asked questions about vitamin and mineral supplements. So what they found in this study was that the participants, the participants that took an average of 820 milligrams a day of calcium had a 31% lower risk of heart attack than the ones in the bottom of the calcium intake, taking less calcium. Those whose calcium intake from all sources, including supplements, was higher than 1,100 milligrams a day, did not have a significantly lower risk of heart attack than the bottom intake group. However, when they looked at the supplements only, they found that participants who took calcium supplements, so calcium pills, on a regular basis had an 86% higher risk of heart attack. Well, that sounds awful, doesn't it? Well, much more than people who didn't take any supplements at all. But the researchers conclude that increasing the calcium intake from diet might not confer real good cardiovascular benefits, but the supplements, they really seem to raise heart attack risk, so they should be taken with caution. But this study really had problems. For one thing, the study was set up not initially to look at cardiovascular issues. So they decided afterwards, oh, let's do that. Let's also include that in it. So when you do a real good clinical study, you have one group that's exactly the same as the other group as much as possible. They're all the same age, they all smoke the same, they all have all the same risks. Well, they didn't really do that. And the group that was taking the calcium supplements, they had a lot more smokers and people who had high cholesterol. And they had a whole lot more heart attacks. Okay, so was it the calcium, or maybe was it some other factors? So it was not a well set up study. And so you have to take those results with a grain of salt. Okay.
So what's the recommendation on calcium?
I'm so glad you asked.
I can go back to slideshow, yep, and then do from current.
From current. Hey, there we go. Okay. So, what are we supposed to do? See, we knew that was coming. That's my husband. He said he'd come tonight in case there are any women who needed help with breast self-exam. I said, I don't think we're going to need your help. Thank you very much, honey. Anyways, so what are we supposed to do? The National Institutes of Health suggest calcium 1,200 milligrams and vitamin D 600 international units for women aged 51 to 70 to prevent fractures, because it does seem to decrease hip fractures at that dosage. Keep calcium below 2,000 milligrams a day and preferably in the diet. And then the U.S. Preventive Services Task Force recommends 600 to 800 international units of vitamin D for older adults to decrease the risks. I called up Dr. Cottrell today. He's the doc who's the osteoporosis guru here in town. He's a lovely person. He does your bone densities, and he really spends a long time talking to each person. He's great. So I asked him, well, what do you do? And do you take this German study seriously? And he said that he also understands the German study had a lot of problems with it. What he does is he recommends, first of all, for women over 65, when they take calcium, they take calcium phosphate, because that's what your bones are made of and that's what you need the most. Younger women, the calcium citrate is fine. Calcium phosphate's good for all women, especially for women over 65. Calcium carbonate really has to be taken with food. Calcium citrate does not need to be taken with food so much, but it's probably better taken with food. And really, it's best to do calcium in your diet. So he recommends 1,200 milligrams of calcium phosphate a day with 2 or 3 servings of calcium-rich foods. Calcium-rich foods are what?
Broccoli.
Broccoli, good. Dairy, of course. What else? Kale, very good. Chinese cabbage, everybody eats that. Canned sardines. I don't know who eats those, but yes, I like them. Calcium fortified orange juice is a great one. Tastes just like orange juice. It gets kind of that like whitish stuff in it, but that's all right. It tastes fine. Calcium enriched tofu. I think all the tofus are calcium enriched, and calcium enriched cereals. So those are good foods for you to take. Now the problem with calcium seems to be in the supplementation. The thought is If you eat just your regular diet and McDonald's and soda and stuff during the day, and then you figure, oh boy, I was really bad, I need to really take calcium today. So you take 200 milligrams of calcium in the evening. One thing, it's not going to be absorbed well, but also the calcium that is absorbed is going to make your blood levels rise real high quickly and then fall and not be that helpful. And it's thought that taking once a day a large amount of calcium, that may lead to some heart problems. Plaque that blocks your coronary arteries, you get some calcium in those. And so it's thought that much better just get calcium in your diet. Eat calcium-rich foods, and any calcium you're going to take it with your food. And it will be absorbed better, and you won't get this massive increase in calcium in your blood. So that's a recommendation. Breast cancer. I've been talking for a while. I'd like you to do something. I would like you to turn to the person next to you or behind you and give them a pop quiz. I'd like you to take just 2 minutes and think of something that you learned that you didn't know before, and ask the person next to you the answer to that question. You have to know the answer yourself, and then the other person asks you a question. Okay, this will help you remember things better, and maybe you'll learn something new from your partner who heard something different. Okay, go ahead.
Okay.
And if you really can't do this, there's detection, diagnosing, and risk factors. Signs and symptoms. Early breast cancer doesn't have symptoms. Nipple discharge, usually not cancer. It's more worrisome if the nipple discharge comes from one breast, it's bloody, it occurs without squeezing the breast, it just spontaneously comes out, needs to be evaluated. Other signs and symptoms, nipple inversion, you've heard about that. If one nipple pulls inward, especially to one side, it's more worrisome. Skin changes like redness, changes in texture like peau d'orange, it has an orange peel kind of texture, that's more worrisome. Puckering, a puckering could be a cancer inside. Cancer comes from an old Greek word, or a crab, and you think of the way a cancer looks inside there, it's sending out all these tentacles out in the surrounding tissue and growing and pulling some of it in. So if you see a puckering on the skin, it could be a cancer that's kind of sending tentacles out and causing the breast to be irregular. And breast pain is rarely the only symptom of breast cancer. Detection, mammogram. That woman is having a mammogram. Mammogram is an x-ray of the breast. Screening mammograms are done in women who have no problems at all. It's just you do it to make sure you don't have any cancer, you don't have an issue, no lumps, no problems. A diagnostic mammogram is done when you have a new lump, you have an area that's painful or something's different about your breast, then you get a diagnostic mammogram where they look really closely at that one breast in that area to see where there is a problem. Ultrasound. Ultrasound uses sound waves, and usually if there's some kind of lump in there, after a mammogram, then they'll use an ultrasound, because an ultrasound will show if a lump is solid or fluid-filled. If it's fluid-filled, usually that's just fine. And if they want, they can put a needle in and draw the fluid out. And that's just almost, if it's fluid in there, ipso facto, it's normal. If it's solid, that's not so normal. So then they may need to follow up on that. MRI. MRI uses a massive magnet. It can detect very small areas of the breast that are abnormal, but it's so good at finding things that you do get a problem with overdiagnosis, or which leads to overtreatment. You find little things and the MRI says, oh, there's a little place here, it's maybe a problem. So then, you go to biopsy or other imaging, and it gets expensive, and biopsies are not fun, and so false positives are a problem with MRIs. Also very expensive. I don't know what they cost, probably about $2,000 or something like that, I think. Yeah. Thermograms. I include this not because I'm advocating thermograms, but I've had women ask about thermograms. Thermograms are a test that doesn't look at the structure like to find a lump, but it looks at the vascular situation, and if the vascularization is going more to one area, then it'll cause more heat in that area. So if there's one area where there's more heat, there could be a problem. So a few years ago, it seemed more women were asking about thermograms. In 2011, the FDA came out saying thermograms do not replace mammograms. Mammograms are a much better test, and don't let anyone tell you thermograms can diagnose anything, because they can't. So the FDA kind of came out against thermograms, but I just wanted you to know that they are out there. Some women will ask for them. I feel like if you want to get one, sure, if you want to pay for it, but still get your mammogram. Breast biopsy is the only way to diagnose breast cancer, and that can be a needle aspiration or a core needle, where a thicker needle is put in and they get the core from the inside of the needle to look at with biopsy, or an incision where they actually cut and take out a piece. And if they do find breast cancer on a biopsy, then they always test that tissue to see if it's responsive to hormones, and they do some testing on it to see what's the best kind of treatment to give for breast cancer. Risks of breast cancer. What do you think is the one main biggest risk for breast cancer? What do you think?
Genetics.
Sorry? Smoking, you say?
Heredity.
Heredity? Overweight.
Smoking.
You got it. Being a woman is the biggest risk for breast cancer. That's right. Actually, 1% of all breast cancers do happen in men, but much more being woman. Being older. Also, as you get older, you become more at risk for getting breast cancer. I have lots of statistics, but let's just go on. Your risk, being a woman, you have a risk 1 in 8 of getting breast cancer in your lifetime. Another risk is heredity, and the BRCA1 and BRCA2 genes. Can't remember everything I wrote about this. These are genes that everybody has, but if you have a mutation in these genes, if you inherit the mutation from your mother or your father, then you're much more apt to get breast cancer. Race and ethnicity, and what is it? African American women are more apt to get breast cancer when they're older, I think it is. They're more apt to die of breast cancer than white women. Hispanic, Native American, and Asian women are much less apt to get breast cancer. It's interesting, there was a study of Japanese women in Japan, and in Japan, their risk of breast cancer was very low. Once the Japanese women came to the United States, their risk became the same as other Americans, a much higher risk. So it must be some kind of dietary thing.
I have a question. Is there like a blood test for that gene, the genetic thing? to see if
Absolutely.
you're carrying
It
that?
costs, last I heard, it was about $3,000 to do it.
Wow.
Yeah, it's probably coming down
So
with
it's not
time.
everybody's chance.
The thing is, 15% of, let me see, 15% of women who get breast cancer have breast cancer in the family. And this doesn't sound right, but 5 to 10% of women who get breast cancer get it because they have the gene. Well, some women get breast cancer and their mother had breast cancer, but they don't actually have the gene for it. So you'll have more women getting breast cancer when there's breast cancer in the family than just women who have the gene. You follow that? Yeah. Did I answer your question? You did, forgot. Hormonal causes. So taking hormone replacement can increase your risk of breast cancer. So what I do is, I have a lot of women come to me at menopause and they're like, I'm going to do the natural thing. It's okay that I'm getting older in menopause. I'm not going to do hormones. You know, I'm feeling okay, and no, I'm going to do the natural, no hormones. And they hadn't had a period in a few months maybe. So many times they come back, oh please, please, give me hormones, please. I can't stand it. I'm having hot flashes every 10 minutes. I can't sleep at night. I wake up drenched in sweat. I have to change the sheets of my bed. It's dripping wet. I was like, okay. And some women are very, very against taking hormones. But then they get to the hot flashes and the mood swings and they're ready to kill their partner and who they love very much, but they can't sleep, their joints ache. And they're like, oh yeah, okay, I want some. It is okay to take hormones. It is. It really is. And especially for younger women who go through menopause or have a surgical menopause where their ovaries have been taken out, yeah, you can take some hormones. It is okay. I mean, if you've got family members with breast cancer and you take hormones, okay, then you really want to do breast exam on yourself. You want to make sure you get the mammograms. Maybe you want to get MRIs. But it is okay to take hormones as long as you understand there is some risk there. But you can feel awfully terrible if you don't take hormones for some women. You know, some women go through menopause and they're like, oh, hot flash, oh, sometimes I get a little hot. No, that's not a hot flash. Hot flash is when your face turns beet red, like that woman, and you just drip sweat, and it lasts for 5 minutes, goes away, and then 10 minutes later it comes again. And that's a hot flash. Night sweats, you can wake up dripping, with the sweat dripping off the side of the bed. There's so much sweat. I mean, those are night sweats. And some women, they just find it difficult to work like that. They can't sleep at night. So it is okay to take hormones. You just have to understand some risks. It's not that everybody's going to have those things. Some women go through menopause and they never have a hot flash, believe it or not. Their periods just stop. They're like, oh, I guess I've gone through menopause. Breast cancer risks, obesity, and high-fat diet definitely increase risk of breast cancer. Alcohol definitely increases risk of breast cancer. And the more alcohol you drink, the more risk you have of breast cancer. Something like 1 drink per day increases it something like 1.5 times. 2 to 5 drinks a day, you got other problems, but you increase your risk like 5 times, something like that. I'm not exactly sure the numbers. I don't know if you can tell, that's a continuum. Lack of exercise, that's a risk for breast cancer. Thing is, they don't know how much exercise. In the Women's Health Initiative, they had women getting like 1.25 to 2.5 hours of walking per week, and they had an 18% decreased risk of breast cancer. Women who walked like 10 hours a week only had slightly improved risks, slightly lessened risks. So they don't really know how much exercise or what kind of exercise, but definitely getting exercise decreases your risks. Environmental causes, if women have had radiation to their chest, like especially Hodgkin's disease, women will get high doses of radiation to their chest, often as young women, they're really at high risk for breast cancer. Military women are at risk for breast cancer, quite a bit, and they don't know where that comes from. They don't know if it's because they're exposed to toxins, different chemicals and fuels, or because they work crazy hours, work nights, have high stress. They really don't know where it comes from. They have interestingly found that men in the military have a much higher risk of breast cancer also. They found clusters of it at Camp Lejeune, North Carolina, and Otis Air Force Base in Massachusetts. Camp Lejeune, they have like 80 men with breast cancer, just a really surprising number. So they're thinking it's something in the water, like the fuels that have been spilled or chemicals from the bases and it's gotten into the water somehow. So they're looking at that. But certainly the military gives a really increased risk of breast cancer. And then one of the last risks I was going to talk about is proliferative or hyperplastic changes. And proliferative changes of the cells, proliferative means that cells proliferate, they're growing a whole lot. And hyperplastic means the way the cell is made looks abnormal in some way. That brings us to the breast halo, and I just skipped a whole lot, but I don't want to talk about that. Breast halo. Breast halo is a test that we have at Tahoe Women's Care, and this will look for these proliferative or hyperplastic changes in the breasts. What it is, it's a 5-minute test that has these 2 cups that go on the breast. The cups are real warm, they have suction and vibration, and after 5 minutes, they'll get fluid out of the breasts. Now, about 50% of women that do this will produce fluid, and that fluid is then sent off to the lab, like with a Pap smear. Now, a Pap smear is a test to look for the beginning signs of cervical cancer, right?
Right.
And when Pap smears were first done about 50 years ago, cervical cancer was the number one cancer affecting women. Now, with Pap smears, we detect cervical cancer by Pap smears way before it's cancer. We detect it when it's still atypical cells. We treat those women never go on to having cervical cancer. Now, cervical cancer is like the number 5 or 6 cancer affecting women. So Pap smears have been a wonderful thing for prevention of cervical cancer. The breast halo is an attempt to do the same thing for breast cancer. Now, the breast halo is really recommended for women from about age 25 to 50. Can you do it over 50? Yeah, sure. You can do it up to any age. But women over 50 tend to be menopausal, and the breast halo doesn't feel very good when you're menopausal and you get the test done. It's, I don't like to say the P word, painful, but it is a little bit painful. Women about 25 to 50, they're still menstruating usually. They have lots of estrogen in their system, and this is not painful. It's kind of annoying feel, but it's not really painful. Now, like I said, 50% of women having this test have fluid that comes out. The other 50% do not have any fluid that comes out. A picture of the breast halo. A lot of people think about breast cancer that it's a simple issue. Either you have it or you don't have it. Of course, nothing is so simple in this life. What happens is you have normal breast tissue, and for it to go all the way to cancer, it has to go through several stages. So one of the first stages is hyperplasia or hyperplastic. That means the cells are growing really fast. They look really normal, but they're growing unusually fast. That's hyperplasia or hyperplastic cells. The next step in that is atypical cells. You probably heard about atypical cells on Pap smear. Maybe you or a friend has had a Pap smear. Atypical cells, that means you need to do some follow-up and maybe there's a problem. Atypical means the cells really don't look bad, but they don't look normal either. So the next step in the process is mild dysplasia. Dysplasia means the cells are looking bad. Mild dysplasia, a little bit bad. Next step is moderate dysplasia. The cells are looking worse. Then severe dysplasia, those cells really look very, very abnormal. And then you get to cancer. So you don't just go from normal to cancer like that. You go through these stages, which are thought to take about 7 to 8 years. So if you have the breast halo, you get some fluid. The fluid gets to the lab, and the lab says you've got some atypical cells. That means that you're really at higher risk for going on to getting breast cancer. Doesn't mean you have breast cancer, just like when you have an abnormal Pap smear. If you get atypical cells, you don't have cervical cancer. It means you're really at high risk for going on to getting that cancer. So you want to get some kind of treatment to prevent you from going on to that. So the breast halo is something young women can do, because young women don't get mammograms so much. young women have dense breast tissue, remember, and mammograms just don't show through that dense tissue very well. So that's one of the reasons why you wait till you're older. Wait till you're at least 40 before you get your mammograms, because then mammograms work better. And you don't really want to radiate young breasts. Now, there are some cases where younger women, you'll do mammograms, but you don't do screening mammograms usually in younger women. So the breast halo, 50% of women produce fluid on the breast halo, and those women are actually at slightly higher risk of having abnormal cellular changes in the breast. The women who have no fluid that comes out, that's a normal finding. Well, having fluid comes out is a normal finding too, but having no fluid is a normal finding, but it's a little bit better finding. You're less apt to have some atypical cells going on. So that's the way the breast halo works, is 5 minutes, it costs $50. Now, if you're one of those 50% who has fluid that comes out, then there is a lab fee for that. Usually insurance will pay for that. Insurance does not pay for the $50 because it is a new test and insurance will refuse to pay for anything that's new. I did have a friend who asked me to just speak briefly about the China study. This is the last thing I was going to talk about. I guess, has anyone here read this book, The China Study, or heard about it? Okay. Well,
last summer she did. She did well. It was amazing.
Oh, really?
It was very revealing. There's a lot of proof, a lot of evidence about it.
Okay. I was asked to speak about this because I guess a lot of women in this area have read this book. The China Study was written by T. Colin Campbell, who's a PhD. The book came out in 2004, and it was a look at, it was an observational study of some rats were given aflatoxin, which is a potent carcinogen, which comes from a fungus that grows on peanuts, not penises, peanuts. And the rats were given aflatoxin, potent carcinogen, and then they were given casein, which is a protein found in milk. When they were given casein, they had a lot more cancers. So he came to the conclusion that casein causes cancer, and therefore all animal proteins cause cancer. And in fact, if you have cancer, the way you treat it, he said in an interview, he was quoted as saying, if you have cancer, go to an all-vegetable diet and that will treat the cancer. So his study has been looked down on by all kinds of medical doctors, and that it really doesn't have any basis in anything. You can't do an observational study and really make conclusions about it. So you can see where I stand on this issue. In fact, there have been studies that show milk proteins decrease cancers. In other studies, no one has replicated the study that he saw of giving the rats the aflatoxin and casein and getting more cancers. So be careful what you read. There's lots of stuff out there that can be just really scary, and when you read it, it sounds like, oh my God, this sounds really true, because they put in some things that are true, and you know they're true, and then they go from there and say, well, and this, so then this is true. And it doesn't really make sense all the time. So just be careful what you study, what you read. Okay, thank you. Thank you very much.